in, then that'll be great. So we're glad everybody was able to join us today. You know, I know that we're off schedule a little bit. I know we went back to back rather than every other week. So thank you everybody for joining us today. This is session 5 in our 6th session ECHO trainings that we have in long-term survivorship care. Today's subject will be weight management for the cancer survivor as they move through long-term survivorship care. A couple of things before we get started. We are going to skip next week in light of the upcoming 4th of July holiday. So session 6, which will be our last session, will be on July 8th. Again, 3 o'clock East Coast time. And we had put it out at last week's session that session 6 was going to be kind of a wild card. And we really wanted to hear from you guys as to what you wanted to hear, what did you want to learn more about in that last session. And so far, we've been getting some responses back that people want to be hearing about sexual health and intimacy concerns for long-term survivors. That seems to be the highest vote getter at this point. So if anybody feels really strongly about anything else, whether it's complementary medicine or whether it's anything else that's really specific, I would say to email Jevin today or tomorrow, because we want to make sure that if we're going to have any special guest speakers come in, we want to make sure that we give them enough time to come and join us. We did do the sexual health session for our fall group, and it was very well received. Obviously, there's so much pull in with physical therapists, but obviously, you know, there's so much that goes into that, and that's why, again, we need this multidisciplinary approach to meet those concerns.
And if I can just interrupt real quick, Scott, too.
Of course.
If you think of something on the fly while we're chatting here and you want to type it into the chat, feel free. We'll be monitoring that too. So.
Great, thank you, Jevin.
Yeah.
So that's really our big announcements for today. So yeah, we're gonna launch into, again, we're gonna start with our case study, and then we will go into our didactic on weight management. So Jevin, if you wanna go ahead and pull up our case study for today, that'd be great. And I don't know if you guys had a chance to take a look at this yet, but our case study for today is concerning a patient named Miss V, and she is, oh, Maura, I'm taking your
Go right ahead, Scott. You're doing great.
Oh, actually, yes. So I'll kick off then. This patient, Miss V, came to our survivorship clinic following a diagnosis of stage 1A breast cancer. She did not have chemotherapy. She did not have radiation therapy. She went and had a bilateral mastectomy with a deep flap reconstruction towards the end of 2018. And 3 weeks after that, went right on to hormone therapy, went right on to the anastrozole. One of the things that we should note about Miss V is that she is from Russia originally. And so when we were trying to get all of her records, first of all, you can imagine that was a little bit of a challenge to get all of her medical records from another country. And actually within the context of our interview with her and our meeting with her, comes to find out that when she was living in Russia, when she was younger, she had been diagnosed with ovarian cancer. So she, by the time she got to us, she was actually already a 2-time survivor, having survived ovarian cancer and now this new diagnosis of the breast cancer. And for her, you know, we selected her as our case for weight management because, you know, she, you know, especially in the presence of the hormone therapy, she had put some weight on, and that in combination with having gone through the ovarian cancer surgery and now going through having a bilateral mastectomy with the deep flap reconstruction, was having a lot of body image concerns at this point, as you can imagine. And she was somebody who she knew that she needed to exercise. She knew that she wanted to exercise, but she was one of these survivors who comes in and says, I don't know how to safely exercise. I don't know what I'm supposed to do that's safe and what's not safe, because I've had ovarian cancer surgery and I've had breast reconstruction surgery. So I don't know what's safe and what's not. And so, it kind of started the downward spiral of not doing a lot of activity and therefore putting on more and more weight. And so, so for her, I talked about, kind of a systematic building up of her cardiovascular exercise first, and then integrating some of the strength training later on, but really trying to establish that foundation of cardiovascular fitness. And then as a side note with her, she actually did come to see me in outpatient physical therapy following her survivorship clinic visit. And really our focus for our visits was education. So what is a leg press? And how do you set the seat on the leg press? And how do you position your body on that? And then this is this is the row machine. So how do you position your body on the row machine? And how do you know what weights to start with? And so many of our individual one-on-one PT sessions, which came as an outcropping of our survivorship visit, was education. And she remarked that after 6 or 8 sessions coming in for one-on-one therapy, she said, not only do I feel stronger, but I feel more confident now. She was right before, and this was right before the COVID shutdown, but she was investigating gyms in the area, saying that now I have the confidence to move forward and do this on my own. But I needed this bridge. I needed somebody to take me through this, somebody who was competent and knew what my limitations were, but also what my strengths were to move forward. And because she was exercising more consistently, she started to lose some weight. And interestingly, she, and I didn't get a chance to really get a sense from like a DEXA scan perspective, but like her physique started to change. Like you could actually see her starting to get some muscle definition. And she even said that she had put on a pair of pants that she hadn't put on in several years. And so those are some small victories that we really need to celebrate for a survivor like this who comes in and and is having concerns with their weight management. But obviously we can't do that in a vacuum, and so this is why we saw her through our survivorship clinic. So Maura, I'm going to have you touch upon what some of your strategies with her.
Okay, thanks, Scott. Hi, everybody. So when we talk about weight management, I really prefer to describe it as energy balance, where it's what you're eating, but also how much you're moving. And for a lot of people, they don't make those connections. They don't put the 2 and 2 together. Weight management is dieting or it's exercising like crazy. They don't see that the two are related and work synergistically. So that's why I emphasize energy balance. And it's the beauty of being in a multidisciplinary clinic with having Scott taking care of the exercise piece and making that connection. But it was interesting for her. She came, a couple of things. She did, she was obese. She was a BMI of 31. She was 225 pounds and gaining. She was up to she was 225 pre-diagnosis and then 233 when she came to us. And so she was concerned. She was gaining weight. So she started dieting on her own. And the way she did it was she cut out carbohydrates and she went on a high protein way of eating. And the thing is, she just was 3 months out of double mastectomy with a deep flat reconstruction. That's not what you do when you're trying to heal from surgery. So I had to kind of realign her, fuel mix of carbohydrate, protein, and fat, and kind of explain that to her, that how to get her off the concept of dieting, wrap her head around she needs to heal. And in order to heal, she needs to nourish her body. And she was open to that. So that was the first part of the conversation. But then the second part is that she just immigrated from Russia. So, you know, I have to kind of take into the cultural concerns. And, you know, I have to check my own, we're all learning, you know, our own implicit cultural biases, right? So I can't assume anything, and I have to start asking questions. So, you know, very fundamental questions like, well, who's in charge of food shopping and cooking in your household? Well, it was her husband, okay? She had no autonomy in terms of making food choices in the household. He was in charge. That's just the way it is. So, so I had to start working with that and then go into her cultural foods. So, you know, I was working with food items that are very different from what I'm accustomed to. So there's that challenge. So you really have to, you know, get that understanding of who's in the household, who does the food shopping, who does the cooking, what are the food items that are being eaten, and work it from there. So I found it challenging, but she was open and engaging. So it was, you know, it was a good session. So with that, I'm going to pass it on to Angela.
Hi, everybody. So when we think about, at least from my perspective, when I think about weight management and fatigue and exercise, there's also an emotional component that accompanies this. And she is a lovely, lovely woman. And also we do know, well, with her especially, she has a history of depression and anxiety. And one of the things that struck me with my couple of times that I met with her is that she really struggled with not feeling like a woman anymore. And she really, because of the two types of surgeries that she experienced, right? Having ovarian cancer and now a double mastectomy. So that was something that we spent a lot of time talking about. But she was also really surprised at how well she coped with the ovarian cancer over in Russia, and how she really struggled and was quite fatigued and not doing well when she was here. And so we spent time talking about and exploring what were the things that you did that were helpful in Russia, and what were the things that maybe you could try to replicate here. And she really like caught on to that. That was like really intriguing for her to think about. And she and I did a lot of exploring, and she said, you know, I connected with others. I was the one that would always talk to everybody else during treatment over in Russia. And so she realized that doing things for other people is what really helped her feel good and help cope. So we did talk about, she did have a mental health professional in Russia who she met with regularly. She wasn't interested because she wanted to try to do this on her own first. So she really got hooked into integrative medicine. You know, I provided her information and education about the helpfulness of mindfulness meditation, and that was something that she started doing. And then she got interested in the yoga classes and things. And also through integrative medicine, we had this, we've done it a couple of times now a year. It's called Smilo Rocks. And it's where patients paint rocks, and then they put it in our healing garden, and then you can come and take a rock for you and then take a rock for someone else. And so she really got into this Healing Rocks project and painted a lot of rocks that she gave out to many people as gifts. And that made her feel really, really good. And so, and with that, I'll turn it over to Jevin.
Thanks, Angela, and thanks, guys, for talking about your visits with her a little bit. So I have the luxury of seeing her not only in Survivorship, but also in our breast medical oncology clinic with Dr. Sam. She's actually a patient of ours. And so I was able to follow up with her actually after our Survivorship visit as well. But let's start at the beginning. So at the time of the Survivorship visit, you know, she came in with a number of side effects that she believed were all related to the anastrozole she had been on. Hot flashes, which we know is one of the side effects from it. She'd been having some nausea. She'd been having some reflux symptoms. And all of these do have a nutritional component to them as well. You know, the hot flashes, certain triggers, things like caffeine, spicy foods. So we talked a little bit about that. And then with her nausea, it was a matter of eating in the morning when she, was able to get up in the morning and eat. And her reflux, similarly, again, some of those foods that can be triggers for reflux with spicy foods, highly, carbohydrate or sugary fatty foods, things that cause more stomach acid to be built up. So those were some of her concerns, but chiefly among them, I would say, she had a lot of distress about her body image. Coming out of the surgery, she struggled having bilateral mastectomies. She felt like she couldn't feel like a woman anymore. And part of that component was her weight management, recognizing that she had gained weight since and was struggling with that body image. So she came through Survivorship Clinic. We talked with her about, the different recommendations for exercise and healthy eating and being mindful of her situation and ways she could cope with it. And actually, she came in only 3 weeks later for follow-up at the breast center, and she had done a complete 180. All of her side effects were resolving, or either had completely resolved or were improving. Her mood had improved and lifted. She felt a lot better with where she was at. Introducing some of the dietary changes that Maura had spoken with her about, some of the exercise changes Scott had spoken with her about, and some of the coping strategies that Angela had spoken with her about. So really it goes to show that multidisciplinary effort coming into play here. And even some of the side effects that we spoke about at the visit, things like hot flashes, for example, had gotten a lot better from some of those dietary changes. And then also she introduced Remifemin, which is a supplement of black cohosh, which helped her quite a bit. So again, it was really, I felt so lucky to be able to see her after that visit so soon and see how quickly she had improved.
Can I just add to this discussion, because I had met her as a new patient, it just illustrates how you don't know as a provider sometimes what are all the things somebody is dealing with. So when I met her, she'd come from Russia. She had had this ovarian cancer diagnosis that required chemotherapy, was not, of course, naturally like something that she had any desire to repeat. And so a lot of our conversations were about oncotype and risk management and is she going to need chemo or not? And I would have never guessed that, subsequently all these other issues were coming up, and maybe we would have gotten to it in follow-up, but I do think this just illustrates the beauty of a safe space to address these other issues. Because when I'm with her, she's talking about, is my breast cancer going to come back? What are we going to do? What if I need chemo? And then this group is a different group to concentrate on different things.
Yeah, thank you, Dr. Sapp, for adding that. And I will say just quickly too, as Angela was talking about those Smilo rocks, Miss V gave me my first ever Smilo rocks. So it's a little painted snowman, which I have on my desk. So it's I cherish that. So I want to open it up to questions before we move into our didactic. Either unmute yourself or put in the chat room. Does this remind you of anybody that you've seen in your practice? Have you come across somebody like this? Whether it's and regardless of what phase of treatment they are, like whether you're seeing them in inpatient or you're seeing them in outpatient, just we want to open up to questions before we move on.
Or maybe there are some strategies for weight management that you've utilized and could share with us and everyone here.
Kathy?
So I just have a question. Like when they come in and you start talking to them about these like dietary stuff, there's a whole lot that you can go on about, like bone density and like you said, sexual issues. Like, do you just offer do you just tell like what the patient has questions about, or do you go into some, like bone density is big area, you want to do resisted training, or do you say do resisted training but do you skip, like I don't know, like how much do you tell them? Because you don't want to overwhelm them with information, but you want to make sure that you're giving them enough to go forward with?
Yeah, that's a great question, Kathy. And yeah, you're right. I mean, when we do our pre-clinic huddle, Jevin does this amazing job of pulling together their medical records, and we get their, some of their intake forms ahead of time. So sometimes we're cued into that ahead of time as to what their concerns are. But yes, you're right. As providers, we're all going to have our little checklist in our head about, what are the questions that we need to ask. But I think we've talked about this before, and I know, Angela, you talk about this beautifully, is that, we need to meet them where they are. And so sometimes, if they just need to get something out, then we are there to listen. And that's why, we'll follow up via email, we'll follow up with a follow-up visit. Sometimes, I mean, typically our follow-up visits are 2 months, 2 to 3 months afterwards, but if we need to have somebody come back in sooner, then we can do that too. We have some flexibility with that. So you're right. We should have a preconceived notion of, what we want to address. But we can also, like I said, we have to be listening to the person sitting in front of us at that moment, and address those concerns first and foremost before we kind of delve into our list.
Well,
What do the rest of you guys think?
Well, and I was just going to comment on the intake forms. That really helps us start where the patient is at also, right? The brief fatigue inventory, the distress thermometer. We ask them to identify their top 2 concerns of what's bringing them to the clinic. So that really allows us to utilize our time with us the most effectively as well. Anybody else?
I use a technique when the person comes in, after I introduce myself and say, I'm here to discuss about, how you're eating. But I always say, but I'm offering you have the floor first. What are your questions? What would you like to talk about nutrition with me? So I give them that opening. And then that tells me a lot, because, they'll pick they'll pick a starting point, and they'll say, well, what's really concerning me is this, or, so that really is my cue. And I find that's really helpful, in addition to the intake forms. But again, through just counseling, you learn people can really let them lead the discussion. And I'll say, what are your most pressing nutrition concerns? And we take it from there. And I usually find that to be very effective.
And Kathy, I like your example that you brought up too about the bone density scans and all those aspects that affect bone density, because it really is a multidisciplinary concern in and of itself, right? So when you have a team like ours where you can have different parts of that information discussed with that person all in one visit, it's really helpful. So like I can talk about the recommendation for going every 2 years to follow up on that. And then Maura can talk about the nutrition and dietary aspects of that and supplements that can help. Scott can talk about some of the weight-bearing exercise. And so it really does lend itself well when going through the survivorship care plan. I can say, and you can, if I'm seeing them first, I can say, okay, and you can talk with Scott about this and talk with Maura about that, or talk with Angela about that. And if you're not in that sort of role or in that sort of clinic, I think, bringing up those things as they come along with respect to what their concerns are coming in that day is something to keep in mind too, as the rest of my team here mentioned. So great question. And Tara, I saw you on mute. I don't know if you had something you wanted to add.
Yeah, I'm just curious, in the crowd, what are the other patients that you see that have manifested with weight concerns? Like what are the themes that you see or the concerns that are told to you? It's often a hard topic to broach yourself, right? But what cues do you hear from patients that say, I have weight concerns?
We actually have a screening question on our intake forms in our clinic. We just do the PT and we have an OT. And we actually do ask about recent weight gain or loss. And so it's in the same checkbox. And so that triggers me to then ask, oh, is it loss or gain? I haven't thought as much about gain because I think loss is what, as a PT, I look at a lot, because with loss, I also tend to see muscle loss. But it's also valuable to see the gain, and, they'll kind of respond differently. Some are like, oh, I've gained some weight, but I'm getting through, it's fine. and others are like, yeah, well, with COVID and, with chemo, and you get this kind of different response.
That's a really great point, and that's why the umbrella of weight management can really be again tailored to the patient. For some patients, yes, they've put on weight and so they want to get the weight down, but absolutely, for your population that you're talking about, we want to make sure that they are keeping their weight on, and so to be able to get them early on so that they're not losing weight. We want them to be a healthy weight, and like Maura was saying, like this energy balance, to maintain their energy balance as they go into, a chemotherapy regimen, or they go into surgery or that sort of thing. So weight management can be either end of it, depending on, again, how the person is presenting to you in that moment. Any other questions or comments? These are great questions and comments. I love it.
Elizabeth, in my crew, I have a few people joining remotely and we have a few in the room. We have had tighter restrictions about numbers of people who can meet together. So anyway, I think collectively what my group has encountered is more the patient who may express some concerns about energy balance, weight management, and then we discuss some possible strategies, and they say, can't do that, 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 can't do that. So I've been a primary care doc for 20 years, so I try to approach it from every angle under the sun, and then sometimes even step back and say, hey, how do you think I might be able to help you with that? But I think more often than not, we see folks who are in the pre-contemplative phase of trying to make some change, if that's the correct term for the, I don't know if that's the correct term, that's what I use. So
we know what you mean. We know what you mean.
I have a strategy for that because as a dietitian, you can imagine I run into that a lot. So I kind of switch gears, and I have a couple of phrases for that. I go for the lowest hanging fruit. What's the single dietary habit that we could discuss that maybe making a change to that would have the biggest return, biggest bang for your buck? So sometimes it's just that one thing. It's always a negotiation, right? It's like, what are you willing to do? And it doesn't have to be perfect. Sometimes it's just a modification or a reduction. Those are all important steps towards wellness. So, I'm never one to hand a printed diet sheet and say, eat this way, because I know that goes in the garbage pail as soon as they get home. So it's more like, tell me what you're doing. And sometimes it's as simple as what they're drinking. What are their, are they drinking a lot of, sugar laden beverages, or do they have a heavy Starbucks habit? Nothing personal, Angela, because I know you do, but you have a healthy Starbucks habit. But the ones with like all the added sugars and fats. So like that type of thing. So I kind of, I call that I go for the lowest hanging fruit to get the biggest bang for my buck.
And I was gonna say we'll have to tell the story about the Red Bull person that we saw several years ago, but I want to be mindful of our time to make sure that we have enough time to get to the didactic as well. Any final thoughts before we move on to that?
I had a quick question, if that's okay.
Sure, of course.
How about weight gain due to prescriptions like medications? Some patients, so again, my basis or my knowledge is in the BMT hematology world, but there's certain medications that do get prescribed that patients become more fluid overloaded, and just the weight gain from fluid can be extremely debilitating for some of those patients with their proximal weakness. They struggle getting in and out of bed, upstairs, causes falls. How do you address that per se when it's not necessarily an eating habit or a nutritional issue? It's something that's maybe more out of their control, but a medicine that they're prescribed to take, and that they can't really control it. They're gaining weight and they're doing everything they're supposed to do, but they're having troubles because of it.
Yeah, that's a great question, Scott. So again, thinking about medications that might be affecting weight gain, whether it's fluid increase or just overall weight gain. we deal with that a lot with breast cancer survivors, people who are on endocrine therapy and have weight changes related to it. Obviously too, thinking about cardiovascular side effects from chemo, and if someone's, say, on diuretics for some fluid buildup. So first, a message that I think we all try to send across is focusing on having them focus on nourishing their body. What do they need to be doing to make sure they're eating right, and what they need to be doing for, whatever diet they need to be following, if it's a cardiac diet or diabetic diet. And Maura, helps talk a lot about that in our visits. And then, what exercise can they do considering their physical limitations? And, I'm sort of preaching to the choir with a lot of the physical therapists here too, but from the medication side of it, it's a conversation, right? So if one medication, say, for example, some of the endocrine therapies, we have options between different aromatase inhibitors and tamoxifen, for example, with breast cancer survivors. If one of those classes might not be working, we can have them go back to their oncology team and maybe try another. Or, for example, with the diuretics, if it's a matter of, they're continuing to have fluid increase, they might have to go back to their cardiology team and talk
Jevin,
with them about.
I don't want to cut you off, but I think, also just to give Scott Capozza, if you have any additional insights, because I think Scott Kramer, maybe you're referring to sort of a more of an inpatient setting with your patients who are in recovery or dealing with GVHD but hospital. I don't know, maybe I misunderstood the question, but weight gain and breast cancer is a problem, but also weight gain, what you're describing, is a medical condition that happens to so many inpatients.
Yeah.
And
especially like steroid use, treatment of GVHD. You see a lot of edema, a lot of overload to the lower legs, but also throughout the abdomen. And it's not always adipose; it's sometimes fluid. But even though they try Lasix or they try some sort of diuretic, doesn't mean it always alleviates the symptom or the issue. And when they start to develop any sort of proximal weakness, getting out of bed, climbing stairs, even just walking, and they could be eating appropriately. Some of them may be eating too appropriately. It just depends. But we talk about weight gain, but there's multiple ways that a person can gain weight, and it's not always via nutrition or having an appropriate diet. So.
Yeah, I think, to kind of wrap up this part of the discussion, and it's a great question. I think, again, and I know we talked about it a little bit last time, kind of like the interaction, to make sure that that they're not taking any supplements or multivitamins that might be, having some sort of effect on those steroids or that medication that could be contributing to that. And for us as the PTs, maybe we need to think about our intervention being like, rather than a 30-minute session of rehab, maybe we need to spread that out, so that they're doing a little bit of exercise throughout the day to try to maintain that muscle pump and to kind of help with that. So I want to
say one last thing is just empathy, because there's a lot that you can't control. And I think just acknowledging that it's nothing the patient's doing, and hopefully things will resolve as the patient gets better. So.
Yeah. Absolutely. With that, I want to make sure that we have time to dive into our didactic. So, Jevin, if you don't mind pulling up those slides for today.
Yep.
And if you keep going, we affectionately refer to today's session as the woolly mammoth presentation, which Maura will tell you about more in a minute. But Jevin, go ahead, kick us off.
Sure will. All right, everyone. Oh, there we go. So what I think about when I think about approaching someone about weight management, whether it's with regard to their nutrition or their exercise routine, their physical activity, is that first and foremost, this should be a routine thing that's being brought up during the visit. And again, as I mentioned before, to a lot of the crowd here, I don't have to beat you over the heads with this because this is what you do. So sort of preaching to the choir, but less than 40% of primary care providers counsel on physical activity. Elizabeth, I'm sure you are not one of them. And overall, over 30% of providers actually ask about physical activity and nutrition. And it's because there are a number of barriers, right? There's lack of training, there's lack of guidelines, there's lack of time during the visit. And so these can all be things that contribute to that not being the case. So what's important when I'm talking with someone about it is to start simple, asking them the basics. Tell me about what you eat on a day-to-day basis. Tell me about your physical activity during the week, and bearing in mind what their physical limitations are or what their dietary needs are. And then, listen to where your patient's at. You've heard it a number of times today already, but it really helps. And they'll tell you what their concerns are with regards to their weight management or activity. And it'll allow you to address their needs for where they're at as well. So that will allow you to, develop an individualized plan and then give them the tools they need and empower them to make these positive lifestyle changes. So why do we ask? There are a few thoughts here. The first is to reduce the risk of cancer. And there are a number of theories that go into why tumor can grow. And some of them I listed here, inflammatory cytokines, insulin growth factor release, estrogen and other androgens, hormones, etc. And we know there are, at least 13 different cancers that are affected by weight management. And so this is one reason why we talk about this. And the other is just overall health benefits, thinking about heart health, bone health, diabetes management, cholesterol, and overall mood. Ultimately, it comes down to there's no downside to optimizing physical activity and nutrition in someone's life. And then we think about, as an oncology team in particular, how this affects them through the whole spectrum of their care and from every team, whether it's from their surgery and improving outcomes or recovery time to medications they might need or treatment they might need from the medical oncology perspective, or their radiation and recovery from that, or even just the simple message coming from their nursing staff on the ground level. That's where it's important to note this unified message of energy balance and weight management can be beneficial for all of those stages. And I'm going to pass it over to Angela.
Okay, go ahead, advance the slide. Thank you. Okay, so when I think of energy balance and weight management, a couple of things come to mind with regards to how I approach meeting with the patient. One of the things that I talk to them about is just living their life in a mindful way. So many of you probably heard of John Kabat-Zinn. He's the guru of mindfulness meditation. Well, it's important to note that mindfulness is not just about meditation. It's really about a way of living and approaching your life, living each day, staying focused at one thing at a time in a non-judgmental manner. And also when I think about weight management and energy balance, sleep hygiene comes to mind. And so we know there's research out there to support that when people are getting adequate sleep, it helps with weight management. And so I often will educate patients about sleep hygiene as well. So in just looking at this very quickly, these are just some ideas and strategies about how survivors can eat mindfully as well as exercise mindfully. So just being aware of what their food choices and how they're preparing their food and paying attention to how their body's feeling and how it's really about satisfying and being nourished. And with exercise, paying attention to how body is moving and how they're breathing and the resistance and the tension of when they're working out. Asking themselves how they're feeling emotionally, what are the thoughts they're having while they're working out, and also paying attention to their surroundings. And again, there's research out there to support that when we focus on what we're doing and paying attention to our exercise and to our surroundings, we enjoy it more. So with that, I'll turn it over to Maura.
Okay, thanks, Angela. Next slide, please. So I'm going to do a quick review of this. If anyone has questions they want to discuss with me after this or offline, I'd be happy to. So again, weight management, as Scott pointed out, it's both managing weight loss, unintended weight loss in cancer patients, but also unintentional weight gain. But unfortunately, most of the patients that we work with, their knowledge of nutrition is based upon the diet industry. This is where they learn their nutrition, these different diets that are out there. So a lot of what I have to do is undo this misinformation that they have and undo this dieting approach to nutrition. As we know, these diets are designed to fail, but we're up against a massive industry, a $72 billion dieting industry, which really does, it is basically the nutrition education of the public. So what my job is to change that and to cultivate what we call, the healthy lifestyle approach, and it has to be sustainable. And that's where we get into the exercise that you guys take care of, but also the eating behaviors. Angela was just talking about that with mindfulness, in addition to the nutrition. Next slide, please. The trouble is we're up against a food culture that actually is toxic and exploits our biology. There's a lot of added sugar, salt, and fat in the food supply. And then we create the drive-through window where we actually have to do no activity and get handed easily 3,000 calories of salt, sugar, and fat. And then we're surprised when over 70% of the adults in the United States are overweight or obese. Many people don't have this realization that, that the food that's fast and convenient is actually the most food that's unhealthiest for us to eat. Next slide. So a lot of weight management, as again, we're talking here, I'm talking about unintended weight gain, but often job one is just stabilizing weight, preventing further weight gain, and also reframing weight goals for the patients. And this can be a challenge too, because they just have numbers in their head. Like I weigh 225, but I should weigh 150. Well, that's just unrealistic. So I really have to reshape what their goals are. And it's not based upon BMI, but it's really done in percentages from where they're at that moment. Percentage change in weight. So for weight loss, a 2% weight loss, if you're doing intentional weight loss, does confer cardiac benefits. So the good news is it doesn't take much weight loss to benefit the body when you're trying to lose weight. I have to say on the flip side, when you're trying to get someone to regain lost weight, to regain from unintentional weight loss, that's even harder. And what I do is I take a one bite at a time approach. Every bite counts, and get them to eat small, frequently small amounts, and just gradually reintroduce eating again to their body. Next slide. Busy slide, but the thing is weight management is so important that it is the #1 recommendation from the World Cancer Research Fund and the American Institute of Cancer Research guidelines for cancer prevention. Next slide. So when I say what's the best way to eat, well, eat real food, not too much, mostly plants. It's that simple. These 3 lines. Next slide. Another way I explain it to people, and it's a way to get them off of this highly processed food, high convenience foods, drive-through window foods. If the food comes from a plant, eat it. If it was made in a plant, don't. Next slide. And what we're trying to get them to increase more of is colors of fruits and vegetables. You can consider all the colors of the rainbow. Blue, purple, green, yellow, red, orange, white. And the thing is, this is the cornerstone of cancer prevention, and it's the colors that give us the phytonutrients that you see just a smattering there, but there are hundreds of phytonutrients, and these are the compounds that Mother Nature gives us to reduce inflammation in our body and support our immune system. So this is really the cornerstone of healthy eating and for cancer prevention, and just also reduces chronic inflammatory disease such as cardiovascular disease, and even helps manage diabetes. Next slide. So when I take this approach with people and get them away from this dieting aspect, this is what I hear. I look at food differently now. I focus on nourishing my body and planning my meals. And I think about colorful plant foods. I feel better when I eat this way. And this is my favorite part. And by the way, I lost weight. So the focus is on nourishment, colorful plant foods, and the rest kind of falls into place after that. So with that, I'm going to pass it on to Scott.
All right, thanks, Mara. So as we were talking about, especially with our case study, when it comes to our breast cancer population, we see this so often in the presence of hormone therapy. Next slide. And again, as we talked about, a lot of times it's the joint pains that come along with these aromatase inhibitors that prevent people from moving a lot. And then, as we were talking about before, with the bone loss. So again, a big part of what we'll do, those of us for the PTs, is a lot of education, and why we're going to try to skew our patients to do more weight-bearing exercise in the presence of hormone therapies versus non-weight-bearing exercises, because we want to maintain or reverse that bone loss. Next slide. But we also have to make sure that, and I guess, and especially for us, we see a good number of breast cancer survivors that come through our survivorship clinic, but we can't forget the guys either, because, some of our men who are on the ADT therapy, they have some of the same side effects that the women have who are on the hormone therapy. They are experiencing increased weight gain and decreased muscle mass, and their bone structure is in danger as well. So really, for a variety of different diagnoses, we need to be making sure that we're cognizant in all of that. Next slide. So I know I keep going back and onto these new ACSM recommendations that came out in the fall, and you can see for physical function. Sorry. You can see for physical function, which I would tie into weight management, with the recommendations there for cardiovascular exercise as well as strength training. But again, this is, these are guidelines. These are not absolutes. These are not written in stone. So again, we have to listen to the person who's sitting in front of us and understand what their needs are. So, as Scott Kramer was pointing out earlier, with his population, with the BMT population, they might be having unintentional weight loss. And so we might need to skew this a little bit and say, maybe we want you to do a little less cardio, but we want you to do a little bit more strength training, because we want you to keep that muscle mass on. Or, again, like if we have a patient who is putting on weight, but it's more because of fluid retention, how do we disperse this? Is 3 times a week the right prescription, exercise prescription for this person? Or is it spread out more? Is it 5 or 6 times a week for 15 to 20 minutes to try to get that muscle pump going to help with that? So again, these are a great place to start with. But again, we have to take this and then we have to use our knowledge, our clinical skills, and be able to apply it to the person who's sitting in front of us. Next slide. And obviously the biggest challenge that we have so often is, especially in the time of COVID, is motivation and how do we get people to move. So these are just some of the strategies that I will use with our patients, and it definitely has resulted in a lot of creativity, especially over these last 3 months, as far as people not being able to go to gym. So how do they exercise at home? That sort of thing. So I am, these are some of the strategies that I will carry out or I'll bring to people. All right, next slide. I think we're actually at the end. So I apologize for all of the background noise here. This is the one downfall to sitting outside of my backyard, so I apologize for that. But what questions do you guys have?
they've been answered, sounds like.
Did it all make sense? But I think this discussion today has been great because, again, under the umbrella of weight management, we really have to be mindful of who's sitting in front of us and what are their needs, whether it is, that they want an intentional weight loss, whether they need to do an intentional weight gain.
Yeah, maybe even just beginning to recognize the concerns, if it's not a routine part of your practice, to ask in a open, non-judgmental way like Jevin had in his examples, which I really appreciate. Tell me about your activity levels. Tell me what you're eating these days. And if it's appropriate in your setting, those are some ways to bring them up. Gosh, we might not actually go over the hour this time, which is exciting.
So while we're wrapping up here, and feel free to interrupt me if you have any questions that pop into your mind or thoughts. Like we said at the beginning, and I know we have a few more people on now, some of the topic suggestions that were thrown out came in, and the most popular one was sexual health for next time's Echo, and that will be in 2 weeks from now. Does anyone else have any other thoughts on a topic they'd want to hear about? And feel free again to chime in or type it into the chat.
Not to sound morbid, but during a survivorship clinic, do you ever discuss palliative care, hospice, goals of care? If a patient, their fear of reoccurrence, or if it does reoccur, that could be a topic, not necessarily for the next session, but just didn't know how you guys address that, or if you pass that towards like a palliative care team, or if they're part of your team.
Oh, Scott, I love that question so much. Yes, we do address that in the survivorship clinic. I've often used it as a opportunity to address sort of advanced planning. Like, gosh, this was a close call here, and so have you thought about what you would want in the future, but in your population, things seem maybe a little more imminent sometimes, or even a little bit less certain. And there are communication strategies for all of this, and I would be more than happy to go over that. I teach this here at Yale. We have several workshops, just basic communication strategies, and then also kind of 2.0, like goals of care type strategies that really anyone can deploy. It's not specific to like a provider, like a provider with an MD or something after their name. So I'm happy to do that. It's probably more than what we've got time for today, but if you're interested in that, maybe we can even use it next time, like a little bit of a 10-minute discussion on that or something.
And I think sometimes too, I find being in the clinic with the patient, there's a comfort level when somebody's reached that point where they want to start talking about it with me, and they don't feel comfortable talking about it with their doctor. It's less threatening to talk about it with me, and yeah. I can guide them, like you said, with just certain words, guide them to the right people, or guide it in a way that they're more willing to accept it sometimes from us than hearing it from their doctors too. So it's sometimes they start talking about it with us.
I bet they do, because the doctors who we spend so much time and money and effort on training them on how to do this, which we should, but they also hold the treatment keys. And so even my own patients, I'm doing fine. Nope, I'm fine. Like, they don't want to go there because they're afraid that if they get real with me, they might not be able to get a treatment that they want. But if they can start with you guys and kind of really start to explore, what do they want? What are they hoping for out of all of this? I think it'd be great. So that's really, I love to see that interest. Okay, so we're at 4 o'clock, so let's end so we end right on time so we don't go over this time.
So thank you guys. We appreciate you taking your time to be with us this afternoon. So again, we will skip next Wednesday. So we will reconvene for our last session on Wednesday, July 8th, 3 o'clock East Coast time. Again, if you have any questions that pop into your head after we log off, please feel free to email any of us or use the Survivorship Echo email as well. We thank you guys for great conversation. We ask that everybody be safe, take care of yourselves, and we'll see you again for our last session in 2 weeks, okay? So everybody have a great afternoon and take care, okay?
Bye.
Everyone.
Oh, looks like there's a chat. Hold on. Oh, thank you for having us, Desiree.
You're welcome, Desiree. Thanks for joining us.
Yeah.
Okay, anything